Hi, it's Roger Green. This week, all our posted conversations contain completed contents from our year-end interviews, edited only slightly for flow and background noise. This conversation is with our good friend Mazen Noureddin. Mazen's conversation is one part about his year, which included moving from Los Angeles to Houston to open a new research institute and a vast array of collaborations on articles and projects, and one part about the year in fatty liver disease, with his increasing optimism about drug trials and the use of NITs. Mazen talks specifically about his work on the novel mitochondrial uncoupling agent HU6 and his leadership along with Stephen Harrison of the NAIL-NIT Consortium and in general where NITs are headed. Just a reminder, Surfing the NASH Tsunami will have next day coverage of the 2 presentation days at NASH posting the Friday session around 6 p.m. Eastern U.S. Standard Time on Saturday evening and the Saturday session around 6 p.m. Eastern Standard Time on Sunday. And here's Mazen. Now we're here with our good friend Mazen Noureddin, who's been a friend of the podcast since, I think, virtually the beginning. So, Mazen, how are you today?
Mazen Noureddin.
Doing great. Fantastic. It's afternoon in my office and sitting semi-peacefully because we continue to build the largest liver institute in Houston, maybe in West America. And the game is playing Argentina and Croatia. It's outside, and we'll see how it goes.
Do you have a team you're rooting for?
I mean, Argentina is one of my teams. So, I mean, by now, probably Argentina, Morocco. So we'll see.
Okay, fine. And Jörn is back no longer in white shirt and tie. For those who didn't see him earlier, he's not just at home in a normal evening life. Jörn, welcome back.
Jörn Schattenberg.
Yeah, we took some hours off the clock, right? But I'm very happy to hear Mazen, good friend, and over the last year, so many excitements, and I could spend 3 hours with him, and I'm sure he'd cover all that time without boring us, but we're restricted today. Regarding soccer, I think I mentioned that before. It's pretty much over for me. I watch as an interested sports person, but I wouldn't make any bets at this time.
I don't think I would make any bets either, although this is the sentimental semifinal, right? You got Messi on one side and Modric on the other, and they're both brilliant footballers. I think Modric may be a little bit underappreciated, but brilliant, the next Tottenham guy, so he does have that going for him. And one of them will get to the final and maybe win, but why don't we get rolling? So, Mazen, you've had a busier last 12 months than most people. You mentioned briefly the Research Institute. You started the year in LA, and you wound up in Houston and a whole bunch of other stuff. Tell us a little bit about your year, your amazingly productive and eventful year.
Yeah, it started with multiple reasons. A good opportunity to build a research institute, family reasons, and personal reasons, which is very much trying to focus and balance a little bit and get healthier. So the year started between February and May. That was a big transition where I don't want to get too personal life, but I sold a house, I bought a house, I was back and forth between California and Texas. And then I started looking into the future here in Houston, Texas, which, as you know, it's a fantastic medical city. It has the biggest medical center in the world between Baylor, Houston Methodist, and University of Texas, which has MD Anderson in it. And I moved here, and I'm wearing 2 hats right now: a private work, which is my research institute, as well as academic work through the Houston Methodist Hospital, which I chose because it's very equivalent and has similar system to Cedars-Sinai, where I came from. Similar reputation, similar clinical capacity and outcomes. Indeed, that they do very well in liver transplantation, and they're now number 2. At the same time, my excitement has been in the Houston Research Institute, which is still in infancy, but we are preparing for a really large setting with 10,000 to a square foot, with the opportunity expected for 10,000 that will do not just clinical trial, it will do translational medicine and clinical trials. So the academic component will be there. We're going to do phase 1 through phase 3 hepatic impairment studies, but we also have a storage unit that will include 6 -80 freezers, data management where we'll collect samples, and the NAIL-NIT biobanking actually will happen in the Houston Research Institute, which that's part of the scientific excitement that I'm happy to talk about. So a lot to going on. My life is centered definitely around my 2 girls, Naya and Lily. Naya is 4. She found a great place here. You guys know that my wife is Belgian, so they speak, I don't. They speak French at the house, and we found her a school that she can speak a day French and day English, which she's quite enjoying. And my wife, meaning her Franco people, which I think Franco people, they're excited to meet each other and speak French with each other. And the little one, we started before 1 year old, we said that she has her mother personality, which is a good thing. And then once once she started walking, it's like she now owns the world, and now she has my personality, which according to my wife is not a good thing. So, thank you for having me here. It's an honor, it's a privilege, and I continue to make friends in the field, and that's what I really enjoy, having people like you, Roger, Louise, and Jörn, and many others that I can count, and I had many meals with them, and I continue to collaborate in science with them.
So, and then Mazen, I guess the other thing that you did this year is kind of fantastic, is you got yourself in a much better shape, right? You dropped some weight. You look wonderful.
Well, thank you. I did drop multiple sizes, and BMI turned from being not good, so I don't say to what it is, to not a normal, but not too far.
Close enough. You should know, by the way, that we've already had a Matt Damon reference this week for Jörn.
I'm not gonna lean on him tonight.
With all that going on, and everything you've been doing this year, you can walk us through, if you'd like, nail NIT or some of your work in other diagnostics, or something you've done this year that you'd really like to spend some time coring into with us.
Let me start with the fact that I've been blessed to have a good year this year, and I really want to highlight that because I say it genuinely, it would have not happened without the collaboration, the good people I worked with. So starting from amazing people, that my resident Emily Trong, who has published quite a bit this year, and you just give her a project and she will go with it. And I was very happy to hear that she matched in her first choice, which I did not interfere in, which was my previous institute, Cedars-Sinai. Another unbelievably productive person is Cheng Han Nag from Singapore, who I've worked with him very closely, he and Mark Mathia, on multiple projects. And that group, we did multiple studies with Arun Sanyal and Shadab Siddiqui from VCU. I've worked with Naeem Al-Khoury, Jörn Schattenberg, Stephen Harrison, many others. I really don't want to miss any. So there are many things that excite you in life. And in science, I keep going with joy when I try to contribute and just not necessarily produce a large number of paper, or not necessarily high impact. High impact is important, but also high impact that will lead to something that will change the field moving forward. And maybe I see it in clinic one day and make sure it happens. So I think the biggest four things for me that they come across mind immediately is, one, the MRI score, or the MAST score that we published in JHEP. I can talk about that quite a bit, but I don't want to bore you with it. But I'm also glad to see now newer data from other groups showing how small is the indeterminate zone with that score, and how well it does with correct classification. And I can talk about that more. I also want to mention Devin Chang, and which I forgot to mention, who's a high school student that came to work with me, and I asked a professor of biostat at UCLA if he knows how to do machine learning, and it turned that, I shouldn't say that kid, but that kid, he's in high school, does amazing work with machine learning, and he came up with a model that predicted F2, F3, F4 NASH, and F2 and higher very precisely, and we published that in hepatology. So that was another excitement. And another excitement is just happened recently, is a new mechanism of action that I worked with Arun Sanyal and one of the companies on, which is HU6, which is mitochondrial uncoupling. You don't see it in the reviews for pathways of NASH. So this is a new mechanism with potential fat oxidation in the body as well in the liver that we're preparing for publication. But as you know, Litmus Nimble and many others are trying to move away from liver biopsy, and we started seeing movement in that big rock started shifting a little bit. And I think what is being looked at now, a retrospective and prospective analysis looking at correlation with NITs and outcomes. And I'm honored to starting this and collaborating with many people, including Stephen Harrison, Jörn Schattenberg, Naeem Al-Khoury. I don't want to miss other people. There are people from pharma as well. The CEO of Terns, Amy Articolo from Novo, Donna Cryer, the Summit Clinical Research Work, and President Gail Hickson, as well as the CMO, Sophie Janine, and many others. We have really the many world experts, collaborators on this. And one of the good news is that, which we probably should announce soon, that we started getting funding from big pharmaceutical companies that they approved us for funding. And I can see the appetite for big players in the field that they want to move away in quickly with a field without a liver biopsy.
Congratulations, Mazen. That's an amazing list also for the collaborations. And I mean, you're really one of the key people in the field at this time. I think I can say I'm very happy to do some of the work you've been doing with you. Let me pick a little bit on you about the drug development, because really the HU6
yes.
presentation you gave at AASLD was very interesting to me. I found It was well presented, and it was an interesting set of data. My question to you is, do you see more of those mechanisms that might have been trialed, like in obesity or some metabolic disease, spill over into hepatology again? And is this something where you see the interest in the drug development arena in hepatology, particularly NASH, is increasing? We were seeing maybe some ressentiments over the last years, and now you're coming up with a total new MOA, or maybe newly reintroduced to hepatology. Do you see a shift here, or what's your perspective on that?
I don't know if it's quite a shift rather than add-on and innovation, kind of pushing the boundaries. When I say innovation, mitochondrial uncouplers have been around for many years. And as you know, they had previously some side effects issues when the drug was not FDA regulated. So with this company coming and doing it correctly in terms of pharmacokinetics and pharmacodynamics, the MOA worked well without causing side effects. In terms of your question of the weight loss drug is going to spill over to NASH, that is an expected path because, as you know, this is a multi-systemic disease with obesity, diabetes, and dyslipidemia being partners with non-alcoholic fatty liver disease in affecting patients' body. Thus, losing the weight and improving insulin resistance will be the core and the management. There are a few things also with the weight loss medications. As you know, some of the weight loss medications, they have systemic effect, and some of them, they have systemic and liver effects, such as the GLP-1 and glucagon duals. And the duals are probably more attractive because they affect the liver as well, and they might affect, or they do affect the mitochondrial oxidation and hopefully fibrosis eventually. And I mean, even the systemic one, the GLP-1 alone, as you know, weight loss drive everything the right direction, including fibrosis. We still are waiting to see. With that drug, the mitochondrial uncoupling, it was kind of like proof of concept study in a randomized placebo-controlled trial fashion, which was 61 days only. And I can tell you, like, overall 30% reduction was up to 70% in the higher two doses. But when you looked at those that they are metabolically disadvantaged, and here we define it as A1C abnormal, it reached up to 86% for 30% reduction within 61 days only. So that's very promising. But here's the important things, which is pushing boundary and pushing the envelope. Weight loss, or rapid weight loss, or very efficient weight loss, there's a story of causing sarcopenia or frailty or losing muscle effect. And that study, one of the things that we showed that we did not lose muscle, rather it was body fat. And this is where I'm calling for, or I'm proposing here with the weight loss medications, no matter what's the mechanism of action, there are three things that needs to be, or four things to me, now it must be reported. One, are they oral injectable? 2, side effects profile with special emphasis on nausea and vomiting. And if you start having mitochondrial uncouplers and stuff like that, you want to see like heat and cardiac effects and all that. The last 2 are really important, which is, do they affect fibrosis or not? They're going to affect fat and NASH, and I think eventually fibrosis. But the question is, do they really affect it and how long? And we have seen all of the above reported, but I think as experts or researchers in the field, we also have to ask for data on muscle loss and sarcopenia, especially if we're going to use the drugs eventually in cirrhotics. As you know, they have sarcopenia and obesity sarcopenia. So that's how I'm looking at those weight loss drugs.
It's interesting because there were 3 people who were going to be part of our coverage at AASLD who didn't make it either. I think in 2 cases got sick. I don't remember what the third one was, but all 3 of them wanted to talk about your HU6 paper. They were tremendously excited about it for the reasons you just talked about, and felt that it might ultimately be advantaged against the glucagon agents because it didn't have the side effects or safety issues that you just described that went along with rapid weight loss. Louise, I kind of feel like we're in your neighborhood when we're talking about metabolics and multi-metabolic health issues.
Louise Campbell.
All of the work that Mazen's described as fantastic work over the year. We spoke with Hannes Hagström earlier, and he was reflecting at one stage on how young, in some respects from the data set, we're now seeing NAFLD. If we only focus on your NALNIT program, if we only focus on fibrosis, are we waiting and letting these patients develop NASH before we actually are going to step in the younger generation? Or is that going to be the strength of NALNIT? It's going to pick up NAFLD in younger populations, which give us an opportunity to prevent NASH. My second question, or or observation was I'm now seeing more and more people who take semaglutide for weight loss coming in for FibroScans, which, to be fair, so far have been normal after a while. So is that the type of metabolic medication you're looking at trying to get more data off? Because, of course, that's in the real world now, and we're missing data sets from the populations because they're not being screened. So I know that's a few questions in there.
Yeah, so I might have to ask a little bit more details on question number 2, but for question number 1, and let me first praise you for your leadership in the field and talking about preventative medicine and screening and all this, which, as you know, I have worked on that, and one of the things I really wanted to get out of the field, if screening is quite effective, and we wrote that paper in Gastro in 2020, that I was humbled and happy to see the AGA pathway quoting it as the cost-effective analysis paper. So that's the win. I feel like as researchers, we push the field and help our patients. But for the NAIL and IT, actually, there's a different goal and different message. Not more important. The screening and prevention is as important. The goal of the NAIL and IT, and I'll summarize it in a second, and I will give an exciting announcement of now what it's developed to. And Jörn, I probably mentioned it to you or not yet, and since the Scientific Steering Committee met. So then NAIL and IT will do a lot of retrospective analysis that Jörn Schattenberg as well Naim Al-Khouri are leading to fill many gaps in the field. The part B, which I think will answer your question, is which targeted population we're looking for. I think we want to assist other consortium with probably the first consortium that is statistically designed and planned to look at outcomes. So no fibrosis, because as you know, it's a surrogate of outcomes in liver disease. We're recruiting the top candidates NITs, especially if they show in retrospective or small cohort data or pooled analysis that they have some correlation with outcomes. And what we're really going to do is to answer that question, or the famous question or request by the FDA and EMA, which is, I want you to show me that if your NIT or combination of NIT, if they worsen, they predict outcome reasonably, which we have some data, but we're going to do it in prospective large trial design. And more importantly, and this is the most recent update we have, we are going to show that changes in non-invasive testing, meaning their improvement lead to improvement to outcomes. So Jörn, what has been updated, but we still have to finalize it since our scientific committee meeting that included many or really amazing KOLs in the field, the update that we are shortening the term of the study. We felt that there is a need to get this study done within 2 and 2.5 years. We met with many biostatisticians that worked with the FDA and EMA, and now we're targeting that 2.5 duration to get the answer. So in contrast to prevention and screening, Louise, we are going to focus on the group that have morbidity and outcomes, which is F3 and F4, and we're going to have F2s as well. But we want to reach the outcomes within a reasonable time and show what we show. And if the FDA has any doubt that a trial can be designed based on NITs, we will solidify that answer and make sure in 2025 or 6 we have a trial that is designed based on NIT. And when I say trial designed based on NIT, I'm talking about phase 3 registry, even if it's going to be subpart H, but they should go with it. If it happens before that, because I'm hearing some positive signal from the regulators, let it be. Though the positive signal, we are hearing that we need such a data that the NILT designed for. And that's why my new 2 updates in the last 6 months, I know we talked about it multiple times, is a shorter trial design that they will get many newcomers to phase 2B and phase 3, a good background and evidence-based medicine that they can use this NAIL NIT. And because of that, we have seen, or we have which I cannot share yet until we sign the papers, that now we have good approval or final meeting approval from 2-3 big pharma companies. So we're moving forward.
That, to be fair, is really exciting. We see it in practice. We see it in our clinics. We see people regularly monitored with non-invasive technologies, whether it's FibroScan, whether it's MRI, whether it's CT. We see them improve, but we only focus on the ones when we look at outcomes for fibrosis and the ones who deteriorate. We don't actually record very well all of those patients. We get better, we improve their liver conditions, and then we see them less frequently in clinic. So it sounds very exciting, and I'm waiting to see all of that because we see it.
Mazen, for one thing, it should be noted that earlier in the year when we were asking lots of folks how quickly we might get beyond the biopsy, you were 1 to 2 years more aggressive than anybody else. And I think your outside window was 2026, and you're now saying you might actually be faster than that.
I think we're not the only one that are thinking that way or hoping to go that way. I think the Madrigal cirrhosis cirrhosis trial also has designed their trial based on a shorter duration. So we probably will be done around the same time, or us first, but you will have large data set from NASH cirrhosis trial. Hopefully the drug will work on that population there, but ours will be natural history with many NITs and inclusive. So there is a movement now. It's like, guys, let's move, and enough 8 out of 10 screening failures and enough doing liver biopsies that we don't do anyways in our clinical practice. I mean, neither me or Dr. Schattenberg will use liver biopsy often anymore. I could be wrong, but you like biopsy, Dr. Schattenberg?
It's gone down significantly. We're talking to students about a research project, and I was worried I don't get enough biopsies to support this. It's clearly gone down, and most of it is in clinical trials.
And I believe liver biopsy in Germany, I could be wrong, remains a laparoscopic liver biopsy.
It's a little something special that some German centers do, where we do call it a small laparoscopic procedure and actually look at the liver and biopsy it. It allows for more passes, and you can actually stop the bleeding. We probably do it more still than other centers, but it's significantly gone down. But I mean, this is one great example of how the field's really moving forward, and Mazen, for that, thank you for sharing all that new development on NAFLD. And I think you're right, it augments the field. I mean, this is not a standalone consortium. There are a lot of them are asking different questions, and I think by combining those questions across the different consortia, it's really moving the field. And as you said, NAFLD probably has the largest analysis plan for asking the question on the outcome and replacing that surrogate of liver histology. So congratulations.
Thank you, sir.
Yeah, it does have the potential to change virtually every commercial rule that matters, right? I mean, if you can get the screen fail rates down and you can shorten the studies, first of all, shorten the time to get biopsy out of the picture, and then in the process, get the screen fail rates down and provide data that will be more practically valuable to doctors when they then have to take new drugs into practice. You've managed to shorten the time to approval and probably shorten the time to uptake after approval all at once, which is pretty heroic, a word I don't use very much.
That's great. We're fortunate now to have many imagings and other non-invasive testing, FibroScan, PDFF, MRE, price is a different story, ELF, and other biomarkers. We are working on other biomarkers, like that's going to come hopefully in this coming year on metabolomics. But also, I mean, I think Jörn had one of the very first publication in machine learning. We had a paper in machine learning, and I just saw Alina Allen presenting in AASLD a very good data. And I think Ray Kim, our incoming AASLD president, has also published in hepatology and machine learning. So how cool it is that now, like, you can go data mined Epic used in the US largely and just discover all your F2, F3s, and F4s and NASH and F2. And indeed, in the future, will be apps to manage NASH. And we know of some of them, and I don't want to turn this into a commercial thing, but there are a lot of apps now being used, and they're looking into using smart platforms in addition to imaging and stuff like that. So we're moving very technologically savvy.
Yeah, spoiler alert, we're actually looking at an episode in the second half of January, looking at that specific issue about apps and a recent trial that's been announced and what we can learn from that and about other apps that are coming into play.
And just pitching in something, how important this is, I think I realized Argentina scored its first goal, Lionel Messi hitting from the spot. So I think you're going to kick it as good for NAFLD, Mazen.
Mazen, I have to tell you, I know how busy you are. I know you're not catching as many of our episodes as you used to, but we had this conversation the other week where Jörn was talking about the challenges in his practice of everything still being on paper, and you can't get the numbers together because you're going to find them at a fax machine, and they're all over the place. And my specific comment was that the U.S. reliance on EHR, which came out of Obamacare, where the government actually funded it, has put us in just a vastly superior position on the specific issues that you're talking about. If it's all in Epic, and in fact, some of my favorite posters from AASLD were coming from Alina's group on what you could mine in Epic that you could use to machine learn your way into who was at risk without even having to do specific tests on the liver, and you could figure out risk in a hurry. So I think all this is attractive and important. And I was going to note two things in advance here. Number one is that Mazen, they taught me in politics, which was my first career, never thank everybody because you're going to miss somebody. So that was really impressive how many people you captured that you were able to thank and comment on at the beginning of the episode. I just wanted to make sure to get that point in before the end because that's a gutsball thing to do, number one. Number two is I'm really interested in where you think 2023 goes, as is Jörn, in part because, as I noted, at least on the issue of biopsy, you were a year to two ahead of where everybody else, even Stephen, thought it was going to be. And sounds like you might turn out to, if anything, have been conservative, which would make everyone else way conservative. So tell us about 2023.
If we start 2023, I think hopefully we'll have the answer by 2026. And that's the trial design now. And based on a lot of sites, track records, summit track records, other places track records, academic places track records, I think that's within reach. And of course, with the many experts we have. What I'm looking for in 2023, actually, hoping to have a drug approved. I don't want to jinx it, but it's predicted. I know nothing. I have no information. I don't think even any data is read yet. So I look forward to that. And I think that will help all of us, the patients, the field, that we really can reach this statistical significance. We had exciting drugs that in phase 2B, they did very well. This phase 3s are starting. They are ongoing. You commented on that on multiple episodes. From my point of view, I'm involved in many clinical trials that I hope that they will do well. Some of them are precision medicine related and related to genes and all that. So I look forward to seeing those starting and going, and or others reporting. We continue to work on non-invasive testing and natural history. I'm quite excited about, hopefully a paper will be accepted soon using a test for NASH and F2, similar to what NIS4 did, which by the way is being changed to NIS2, but we have a metabolomic test that is performing very well. So hopefully that will be in clinic sometime soon. Actually, it's being commercialized by that company. And again, I don't want to mention names so I don't turn it commercial. So although some people say we're done, we have FIB4, and my opinion about FIB4, that is great, cheap, but it has its own downsides. And seeing the results of phase 3.
So 2023 with the year of drugs and non-invasives both, huh?
Yeah, I mean, we have a lot of non-invasives are continuing to excel and do well. And within, as I mentioned, the period of the next 2-3 years, I think we will make significant change. Don't forget, it's a big field: staging, screening, monitoring therapies, predicting outcomes. I mean, context of use are endless, but we should simplify them and see if one can do more than one COU context of use.
I was just going to add in here that the excitement of being able to speed up the whole trial timeline and use non-invasive technologies, and particularly with outcomes and seeing improvement and being able to track all of that. If we can do that and get that into a relatively good space, then it improves the engagement with primary care. They get excited. They have something they can do within a relatively short period of time, and the momentum is liver. I'm a believer that the momentum is liver because liver's been the one overlooked organ that can address or partly address a lot of the other metabolic areas. It is the elephant in the room in most conditions. So the future is bright. By speeding up non-invasive technologies in clinical trials and getting those pathways, we'll really engage the primary care and treatment zones for that. So that's what really excites me about improving those timelines, Mazen. So well done. And Sean, because you're part of the NIT and Nail It and all of those ones as well. So anybody in that space speeding this up, for me, is vital in that area.
I share Dr. Noureddin's excitement around NITs and drugs and the momentum that's in the field. My initial question, with the multiple MOAs that are still being explored, I think there's a lot of opportunity in the field, and Mazen gives us good reasons to think we might even speed up drug development by, moving that field away from the histology, which has been such a burden for drug development for some time, but still might be leading to a successful approval in the next 1 or 2 years, and maybe it's more than one. So I share the excitement, and I'm glad to be cooperating with him on some of his many projects, and congratulations again.
Mazen, I'm going to use a metaphor because why not? When I got involved with this space in 2019, particularly after OCA did not get approved, it kind of felt like the entire liver field was gasping for breath. And what you were talking about today just takes your breath away from the other direction, right? Which is it could move fast enough that you got to keep up. And that's immensely exciting.
It's a holiday season. It's 2-0 to Argentina. It smells and look Christmassy here. It's good times. I wish everyone great times. Merry Christmas. Happy New Year. And again, thanks, Roger, actually, I did not realize it's 2019. It feels like 2009. And I think this podcast and this show, if you want to say, has actually kept a lot of things relevant and highlighted good things and very highly intellectual. And one of my biggest people I'm a fan of is Scott Friedman, and he came on this show multiple times. And it just, not just him, many other, Arun Sanyal, Steve Harrison, and I don't want to miss anyone, but it just shows you the scientific caliber of this and the high-level talk. So again, I'm honored and privileged to be among those, and thank you for what you do, and to you and Louise, and again, Merry Christmas and Happy Holidays.
And Merry Christmas, and my only closing comment, I'm doing this for my engineer, is that in the background, you might have heard construction during this podcast. Some would say that was the Houston Research Institute. Others would say that was Mazen talking about the amazingly rapid and exciting future of hepatology being built around him as he spoke. I'm going to go for the latter. So when you hear that construction on the podcast, please understand that's just part of everything that's exciting, not disruption in the moment. Mazen, thank you so much for joining us today. I know how busy you are, and great to see you. Great to have you with us, and we look forward to a fantastic 2023. Well, thanks everybody, and Mazen, fantastic. I'll talk to you in a day or two. Thank you. Thanks everybody.
Thanks for having me.
Have a great Christmas.
Bye-bye now.
We hope you have enjoyed this discussion. Please join us again later today for the full conversation between Louise, Roger, and their guest, Ken Kuzi, here on the Surfing the NASH Tsunami podcast.